I'll switch to slideshow here. Okay, I'll try not to push the wrong button here, hopefully. The people can hear me clearly?
They
Yeah.
can.
Okay,
Yeah.
that's good. Okay, so I thought we'd just start with a quick case, and then I'll wake you up a little bit, get you to participate. So my understanding is that we have nurses and physicians taking this course. So I'm just going to pretend that you're critical care physicians in the cardiac.
There's also lots of allied health as well.
And allied health, good. So this is kind of pertinent to EMS as well. So this is a 14-year-old male who was playing basketball and then he collapsed suddenly, been previously healthy. Bystander CPR was started, and then he was defibrillated successfully with an automatic external defibrillator, and he had ROSC, which is return of spontaneous circulation in the field. So in the school where he was playing basketball. He was intubated and ventilated because he wasn't breathing well, and he did have some hypotension and hemodynamic instability. So he had fluid and inotrope fluid bolus intravenously. Intravenous started, and large bore IVs and inotropes. And then in the ICU, he had an arterial and central line inserted and was still in a coma. And in the first few hours, it was noted that he had a rectal temperature of 38.5. So what would you do? What are your concerns, and what would you do to manage this fever? And don't be shy. All answers are good. I just want some participation.
Cooling blanket.
Okay, very good. So a blanket. So you a cooling blanket. So we there's many different types, but we use you could get a blanket, and also you can get a mattress. So you could put a mattress under the patient and a blanket, both, like a cooling. So those many of those units which are filled with either like water, circulated cold water. You can set the temperature. We have many of them in our ICU, and many of them are set up so you can have two units on each console. In other words, you could have the mattress and the blanket. Are some of the kind of things that over time you'll learn to make sure that you can cool rapidly using that apparatus? So sort of it's not a trick question. This is just kind of general principles about heat transmission or taking heat out of the patient. So one of the things we've learned is you just have to be careful not to put too much insulation, too many blankets between either the blanket or the mattress and the patient themselves. And then you have to inspect the skin carefully, because if you don't have much insulation, many of these have kind of like a corrugated surface and maybe fairly hard plastic. So if you're not careful with the skin over time, you could have some pressure induced injury to the skin. So, but my key point is insulation. Don't put too much insulation. You may find you're not cooling the patient. Anything else about how to cool?
Tylenol?
Yeah, we don't find that Tylenol does anything in this situation for some reason. There's such a massive inflammatory response. I mean, usually give it anyways, but if you just gave Tylenol and didn't use active surface cooling, the patient would just get more febrile. Yeah, it doesn't have much of an effect, but it maybe we always give it just in case, in combination with the active cooling as well.
Head covering with ice packs.
Beg your pardon?
Head covered with ice packs.
Yeah, we do. We use a lot of ice packs. So in fact, often what we use, especially if you have, say, this is an adolescent, I didn't mention his weight. If he was obese, it would be very difficult to cool him. And so we tend to use a lot of ice packs. Like literally we get crushed ice and we make sure they're conformed to the patient and that there's a very thin layer between the packs and the patient. Then we'll put like a bear hugger I think the lowest that you can put a bear hugger, which blows air through the ice, is room temperature. Maybe the new units you can set them colder, but blowing at room temperature then as it blows through the ice packs will really help to. So we take this is just the way we do it. We put a water cooled mattress under the patient. In fact, we anticipate the fever. This is important. In this case, I said that the fever developed. What we try to do consistently is make sure that everyone knows that this patient is going to develop a fever and that we prevent it, so that we get the mattress on the patient and then we'll monitor them continuously. One of the big steps prior to treating is to make sure you have some kind of a continuous monitor. What we tend to use in our ICUs is a lower esophageal temperature probe, and that's been shown to correlate with jugular venous blood pressure by some studies in cardiac anesthesia. Does anybody else have different sites that they monitor in their units? That's a question for everybody. When they monitor temperature continuously?
Rectal probe.
You do rectal, eh? The problem with rectal is it can give you a false reading, especially when the mattress is close to the rectum. The rectum can be actually colder than the core temperature of the patient, so you're getting a false sense of security. So we tend to we have a policy in our unit that we always use that lower esophageal temperature. You can get we just put probes in, or we also have esophageal stethoscopes where you insert them and listening to the heart sound, so you know you're behind the heart. So that's basically it. Try to prevent the fever, but if it does occur, you have to be very aggressive with surface cooling to get. And the other, is there a pharmacologic agent you could give to help? People mentioned Tylenol, but anything else to prevent, hint, to prevent shivering?
Steroids.
Pardon?
Steroids.
No, steroids won't prevent.
Rocuronium.
Say that again?
Rocuronium.
Yeah, so some kind of a neuromuscular blocker, right? Rocuronium, pancuronium, whatever you got, whatever you tend to use, cisatracurium infusion, whatever you're most used to using. Yeah, so that if the patient shivers, their cerebral metabolic rate will go up, which is just as bad for their brain as the having a fever. So you need to prevent the shivering, and which will invariably occur when you cool them. Okay, I'll just move on now. So basically conflicts of interest before I start on my presentation. Thanks very much. That was great answers. I think you can all go back to sleep now because you seem to know it all. You know how to treat fever and how to prevent it. Conflicts of interest. My hypothermia therapy studies were funded by the Sick Kids Foundation and Heart and Stroke Foundation. THAPCA trials were funded by the NIH in the US, and we have some recent funding from Heart and Stroke and Mallinckrodt Pharmaceuticals. And can you guys see all that slide okay?
Yes, we can.
Good. Okay, so I started with the case referral. I'm going to talk a little bit about survival trends in pediatric cardiac arrest, then I'll go into hypothermia therapy, and then just a few words about our current trial. So a little bit more, I think my topic was hypothermia therapy, but the key messages are temperature regulation, and we're moving on from hypothermia therapy to look at other neuroprotective agents. So this is a paper that came out in 2019 looking at in-hospital cardiac arrest. So on the x-axis, you've got the different years from all the way from 2000 up to 2018, and then the survival. So you can see this trend over time that it appears that the survival is improving. And it's probably due to a lot of things, including better pre-hospital care and potentially better in-hospital care. In adults, it's been shown for sure that if you do better hemodynamic monitoring and treatment of the hemodynamic instability, example, hypotension after the cardiac arrest, that the patients do better. So maybe better critical care, a whole lot of little things have probably led to this. We published a study more focused on the out of hospital cardiac arrest. It's probably one of the largest studies because we had the opportunity to participate in a very large multi-center database that had been accumulated. And for over 2,000 pediatric out of hospital cardiac arrests, this is just the survival trends over time. So on the x-axis, you go from 2006 to 2012. The lower dots are for infants. The middle dots lined with dots are for children, and then the solid line is for adolescents. So what we showed is that over that 6-year period, that there was a significant trend towards sort of a doubling of survival in the adolescent group, but not so much in the children or the infants. So what about hypothermia therapy? So hypothermia therapy is now standard of care for newborns with hypoxic ischemic encephalopathy. And this is just one of the Cochrane systematic reviews, which was published and showing that there's a significant improvement when you combine all these studies, when it leads to, for those who survive, what about neurological disability? They actually have a significant improvement in their rates of neurological impairment. What about an adult? So there were a couple of studies both published together in the same issue of the New England Journal. This is old history of it going all the way back to 2002. So Steve Bernard's study, 2-center study from Melbourne, Australia. And they looked at only using 12 hours of hypothermia therapy. And then they looked at a good outcome discharge home or to a rehabilitation facility. So they dichotomized their outcome to good or bad. Bad outcome was death or discharge to a long-term nursing facility, whether conscious or not. And what they found is that they had a significant improvement, fairly small study. It was a day of the week randomization. So it wasn't truly randomized, larger number of patients within the hypothermia therapy group. It wasn't 50-50 randomization. It was done in the ambulance, I believe. So they started the cooling there. And there was a significantly higher number with a normal outcome or mild disability. In the same issue, the HACA study, which was a multi-center European study, and it used a little bit of a longer duration. They used a little bit of a longer duration of hypothermia therapy, 24 compared to the 12 hours that the Bernard group used, and that Stephen Bernard's group used. And then they looked at the primary outcome of favorable neurological outcome and of within 6 months of the cardiac arrest, and secondary outcomes included mortality, and I'll go in a little bit into some of the complication rates. So you can see that they did again show in the survival curve a significant improvement, and both death rates and favorable neurological outcomes were significant statistically, favoring hypothermia therapy. However, these studies have been criticized because in the control group of patients, this is the temperature curves over time for the HACA study, the second study. And when you put a 75th percentile T-bar, you can see that 50% of the patients are, sorry, it's not these are the 75th percentile, but this bar represents 37.5. So above that bar, you would have a fever, this red bar, and you can see that that essentially 50% of the control group had a fever. And that may have been why when you compared the hypothermia therapy to a control group, that there was an improvement in the death rates and the neurological outcomes. And when you look at the other important thing is to always, these studies are never powered to actually show significance in the adverse events. They're powered for the primary outcome, which in this case was, in these two studies, And in this second study, the HACA study was neurological outcome. But you can still see trends to increase risk of bleeding, infections, and arrhythmias. So, and then also this is a separate study altogether, an observational study in adults showing that there is that having a fever after the cardiac arrest is a risk factor for bad outcome. So because of this, the group in Sweden went on with a multi-center study in Europe to do another study where they, in adults with cardiac arrest, this is the temperature curve, they randomized them to make sure that that control group was kept. In fact, they kept them a little bit cooler than normal. So there you can see that the mean temperature here in green of the control group was around 36 degrees Celsius. And then the hypothermia therapy group were down to a mean of 33. And they compared those two groups, but the survival curves were no different between the two groups. And when you look at the actual outcomes in terms of the death rates and the neurological outcomes, there was no significant effect. So it appears that if you really aggressively control that and prevent that fever, that the outcomes are the same. Hypothermia therapy offers no benefit. What about children and infants, children, and adolescents? So we published a study in 2009, which was retrospective multi-site, and we showed that there was really no benefit of hypothermia therapy, and argued that like there was no actual, it was an observation study, it wasn't a randomized trial, but that it would justify doing randomized controlled trials. And we went on with our collaborators to do the THAPCA studies, which was a very large multi-center 36-site study in the US, Canada, and Europe, and in children. And there was one protocol, but it was used for two different populations: in hospital cardiac arrest and out of hospital. We published the out of hospital cardiac arrest cohort first in 2015. And this is the temperature curve. So we were cooling for 48 hours and we were aggressively maintaining normothermia in the control group. And there was no significant difference between the neurological outcomes. We used the Vineland score as in the survivors as the primary outcome, and for those, and also in survival. So really, unfortunately, hypothermia therapy didn't offer a benefit compared to normothermia. And I'm going to emphasize again that the keywords are compared to normothermia, and we did aggressive control prevention of hyperthermia, maintaining that control group with active cooling in a normothermia range. And then we then published, we didn't quite get the full powered, the full sample size due to feasibility issues, but we then published the in-hospital cohort. And once again, we were unable to show any improvement in either the death rates or the neurological outcomes between the two intervention groups. So, so in summary, hypothermia therapy and THAPCA, there's no real evidence of benefit. The early evidence of benefits in adults may have been due to inadequate temperature control in the control normothermia group. And should we cool patients after cardiac arrest? Well, we do believe yes, that it's very important to make sure that you actively cool or prevent the hyperthermia, the fever. And at least from that second European study, multi-center study that was coordinated out of Sweden, even cooling a little bit below normal to prevent that fever, we believe that can show some benefit. Some people still argue against this conclusion, saying that there are no randomized trials allowing patients to be febrile versus just controlling them to normothermia. And this is all observational evidence that supports this, but I haven't seen any studies coming out yet where people have gone that far. So in the meantime, the ILCOR international guidelines are to control the fever and to make sure that you keep them normothermic. And so moving on, so we have moved on to, after doing our cardiac arrest studies, we're now moving on we've recently been funded by the Heart and Stroke Foundation in Canada and Mallinckrodt Pharmaceuticals, the INOMAX division of Mallinckrodt, to do a pilot study of nitric oxide. There is also another multi-center study out of Pittsburgh, multi-center adults with cardiac arrest, where they're using nitric oxide after the cardiac arrest. It's only adults, and I think it's only out of hospital cardiac arrest. So that's in progress right now. So our study is not the only one, but ours is the only one that, to our, as far as we're aware, that includes children. So nitric oxide, actually, when you inhale it, it's, as we know, it's usually used for pulmonary hypertension, but it gets absorbed on the hemoglobin, and then in hypoxic peripheral vascular bed, it gets unloaded as a product, which then releases nitric oxide in the microcirculation and can improve blood flow and be an anti-inflammatory compound after an ischemia reperfusion injury. And when you have a cardiac arrest, you really are, every single organ has an ischemia. It's not just the heart and the brain, it's all your organs have an ischemia reperfusion injury. And so there is lots of microvascular dysfunction and lots of areas where there are hypoxic zones. So the animal evidence shows that nitric oxide is indeed neuroprotective in both cardiac arrest models and stroke models in rodents. And most recently, when it's administered during chest compressions in both a rodent and a piglet model, it leads to a higher rate of return of spontaneous circulation, probably because of its afterload effects for benefiting the right ventricle. But in addition, these studies that I mentioned at the top in terms of neuroprotection, that has been shown in multiple different other organs too, in terms of ischemia reperfusion injuries, that when you inhale the nitric oxide, that it improves the outcome of that remote organ ischemia reperfusion injury. So there's two reasons really to try using it in cardiac arrest. So we designed a pilot study, which is 4 centers, and the unique thing about this is that we have 1 pediatric center and 3 adult centers. They're all in Toronto, and 8 different ICUs within those 4 centers. And we're just going to do 40 patients, and we're going to try to randomize half of our patients and rapidly deliver using a deferred consent model, where we just simply randomize and start either placebo or the study gas during chest compressions in half the patients, and then in the other half we'll start it as soon as we can after the return of spontaneous circulation. We do have a time window. If we don't get it started within 6 hours of the onset of the cardiac arrest, then they wouldn't be eligible for the study. There is some evidence that the higher you go with your dose, that your offload to the right ventricle is better. So the dose during chest compressions is going to be different than the dose afterwards. And maybe a higher dose with a surge of oxygen-free radicals in the blood following reperfusion, return of spontaneous circulation. It may be that those higher doses are harmful, combining with those free radicals and creating peroxynitrate, which is quite a toxic molecule. So as soon as we get ROSC, if we start the higher dose during chest compressions, we'll bump down to 20 parts per million. And we'll try to get about a quarter of the patients as children, so 10 children and 30. So we'll use the INOMAX apparatus, and then we'll blind it so that neither the caregivers, the RTs will regulate this, and will not be blinded, but the bedside nurses, bedside physicians, families, and patients will not. They'll be blinded to whether the patient is receiving nitric oxide or a placebo gas. And during bagging, same thing. We'll have an apparatus which is blinded. And we'll give the study gas for 72 hours or until extubated. And it's just starting the study, and it'll take us, this is just a pilot study, and following that, we'll need to do future, in separate studies in both the adult and the pediatric population. So it may take quite a few years before we have an answer to whether this works or not, but we're pretty excited about starting this trial. We did some animal studies. My co-principal investigator, John Granton, and I had a fellow who worked in my laboratory, and so that we've done quite a bit of work leading up to this trial. It's taken quite a few years of work. So I'd like to acknowledge especially my research coordinators and our research manager, especially Arash and Judy. And the THAPCA investigators were very many. I mentioned there were 36 sites in the US, Canada, and Europe. And currently John Granton is my partner in crime. And also we have multiple different investigators at the other 3 sites for this inhaled nitric oxide study. And our respiratory therapist is very, very keen. And we thank our funders, Heart and Stroke and Mallinckrodt. And this study will be conducted on behalf of the Canadian Critical Care Translational Biology Group, which is a national group. And we're going to, what part of our funding, we're trying to use some, to find a biomarker that is a blood test that is associated with response to the inhaled nitric oxide. So that's some fundamental basic science work using proteomics. So that's a very interesting part of this study. So the idea would be it's having a biomarker to show in the future when you start the study, is there a response to the therapy, or will the therapy not be effective, which might direct whether to keep it going or not, as a target of effect, a blood test. And that is it. So I will happily take there you go. I'll happily take questions, discussion.
We'll just check the chat as well, because sometimes people write in the chat.
Okay, sure. Yeah, I'll take a look at that.
Irina said, "Thank you, amazing lecture."
Thank you, Irina. I paid her before the lecture to say that.
I have a question, Jamie.
Hi, Julia.
Hi. I'm just wondering if there has been any research, or if you guys are working on this as well, but just thinking about patients who have been on pump during a cardiac surgery, if having them be hypothermic in the OR and directly post OR, if that's something that's neuroprotective for those patients as well.
Well, yeah, the original research on hypothermia that during the surgery, especially during circulatory arrest, is beneficial, right? So that that's why they always cool, to be neuroprotective. And often in the animal literature, and that did originate from actually some of it was from U of T, some of the original with hibernating animals, groundhogs. But the bottom line is, it looks like when you cool during an event, an ischemic event, as opposed to afterwards, that there's probably more neuroprotection. So that's why that is a practice. It's a good question. Should we keep them cold when they come out? And I don't know if those studies have ever been done, but I think like I said, if you think of the basic science literature, it looks like the actual cooling at the time of the ischemic event is very beneficial, whereas cooling after the event, sure, there's some animal evidence that it works, but it's not as effective as cooling during the event. So that's the history of cooling. So they always cool during bypass, and they go to deep hypothermia, right, during circulatory arrest in the operating room. but it's a great question. I don't know if anybody's aware. I don't think anybody's actually done the studies where they keep them cool when they come out. But I mean, most of them, some of them do have a fair bit of organ dysfunction, but would have to be, I guess, in a subgroup that have suffered some kind of a clinical ischemic event within the ICU, because most of them, many of them do very well, right, and just get better. There's always that subgroup that have lots of complications after bypass and surgery. But yeah, currently we just do it in the OR. Thanks, Julia, for that question.
Thank you.
Any other questions? Oh, hold on. Let me just read the chat for a second.
The CFO check too.
Some thank yous.
Another thank you.
All right. Thank you, Dr. Hutchison, for helping us to understand. For helping us to understand more about the effects of cardiac arrest on the brain and evidence-based strategies for neuroprotection.
And I did send Cecilia my slides, so she'll upload them so you can all have them.
Yeah. Thank you so much.
Okay.
Okay.
Have a great rest of your day and have a great weekend. Bye-bye.
Thank you.
Thanks, Cecilia.
Okay. We're done a little bit early, so we're probably just trying to get one of the other the next speaker up a little bit earlier. Maybe everyone can take 5 minutes while we try to see if Salvantan can present next. So we'll see you in 5 minutes. Everyone, we're going to start the next session at 13:30. Thanks. Hi, Tivia. I'm going to make you the host now.
Thank you.
Just remember to make me the host when you're finished.
Sure. All right, so let me just start by,
Okay, hold on just 1 second.
I may need to log off and back on.
Yeah,